Well, good morning, everyone. We're here from the American Glaucoma Society, live with you. I'm with Brian Francis from UCLA. I'm Albert Khoury from Rutgers University in New Jersey. Excited to be here, talk to you about Vyzulta and practice. Um, we're here on behalf of Bausch. We're on the speaker bureau. This is not a CME event, obviously. I'm just going to go quickly through some safety information with Vyzulta. I'm pretty sure most of you have had experience with Vyzulta. It's been with us for a few years. You avoid using it as a prostaglandin in eyes that are actively inflamed. You want to talk to patients about the odds of hyperpigmentation. Obviously, not on top of a contact lens, for example, because of the preservative. But let's just move on to our cases. We're going to discuss two cases this morning. They're both on the early spectrum for glaucoma. This is the first case. It's a patient with mild to moderate glaucoma. That is, common to a lot of patients we see on day to day. On currently on generic latanoprost. This is the patient information. Younger patient, 54-year-old Hispanic male, has primary open-angle glaucoma, presenting for a checkup. You can see on the slide here, has POAG, cataracts, and is myopic. And as I mentioned, is on a generic latanoprost. Tmax is mid-20s, 25 millimeters mercury. For past medical history, has history of hypertension and is on a beta blocker. Do you take that into account, Brian?
Well, I think it's important if someone is on an oral beta blocker that a topical beta blocker can still be used, but it may have limited efficacy in those patients.
Yeah. What about sulfa allergy? Do you factor that in?
Yeah, sulfa allergy, I think that factors into the use of topical CAI, and there's some cross-reactivity potentially with that drug.
So next here we have some data on the exam. Pretty good acuity, 2025 and 2030. Again, some blepharitis, ocular surface disease, and you can see the cornea has some staining, +2 nuclear sclerosis. Tonometry on the latanoprost pressure is 20 and 21. Central corneal thickness is average, and the angle is open. And that's the optic nerve of the patient. What do you think, Brian?
So I think it's key to note here there is some asymmetry between the optic nerves. Specifically, we're looking at the right optic nerve. So on your left on the slide here, there's superior notching, and you see that blood vessel that's coming out right at that notch. So around the 11 o'clock position, that's something like we call the classic bayonetting. So you don't see the vessel, and then it kind of makes this turn and then comes out where that notch is. The left eye looks pretty good with an intact rim on this picture. We don't see any optic nerve hemorrhages, and it's hard to appreciate any nerve fiber layer defects on these photos.
Yeah, bayonetting is a sign we talk to residents about all the time. It's kind of like we kind of glance over it now that when we focus so much on the OCT. Yep. So, what are your thoughts on the OCT?
So here we have an OCT that we have side by side the RNFL and the ganglion cell complex. The GCC actually looks pretty normal in both eyes in this patient. At a first glance, the RNFL may look normal, but if you focus over towards the right of the slide, you do see some asymmetry between the two nerves in terms of cupping. But also want to focus your attention on the T-snit. That's about halfway down on the right side of your slide here. And the T-snit is the overlay of the nerve fiber layer thickness over a 360-degree circle. And it's an overlay of the right eye and the left eye. And you can see there very clearly that there's asymmetry between the right eye and the left eye, more pronounced superiorly, where we saw that notch. And then such that on the bottom right, you can see the red area that shows that difference between the right eye and the left eye.
Yeah, that's perfect. And then we get a field, and you can clearly see that the visual field test highlights the abnormality noted on the OCT. So there's that early inferior nasal steppage area. The mean deviation is not high, but it's significant glaucoma. Any patient with with field defect, I think, falls more into the moderate stage disease. This is irreversible loss.
Yep.
So in terms of treatment, again, this is a patient, just to remind, is already on a generic latanoprost. We're looking for further reduction in IOP to preserve the RNFL, prevent visual field loss. And what are your thoughts on Vyzulta for patients?
Well, so yeah, so you're making a good point. This is a patient who is young, and so you want to be fairly aggressive at IOP reduction, given that this patient has perhaps 3 or 4 decades of life expectancy. So we're looking at targeting probably a 30% reduction from their baseline. So the baseline was what, 25. So a 30% reduction, you're trying to get about a 7 to 8 millimeter reduction from that level, and you just haven't gotten quite to that level with the prostaglandin that they're on, bringing them down to about 20. So what we're looking for is additional IOP lowering. We have several options. One option which we're discussing here is a switch. So switching the prostaglandin to another drug that may have more efficacy. You can add another drop. You're limited here in this patient because of the beta blocker use and because of the sulfa allergy. You could do something like a laser trabeculoplasty. That's possible. I think this patient is probably not surgical yet at this point. But certainly a good plan would be to put them on a drug that may have more efficacy than the latanoprost alone, yet balances that with excellent tolerability, and you're not going to put additional stress on the ocular surface with adding more BAK to this patient that they're already on.
So key, I agree with everything you said, to keep the treatment simple. One drop a day with the medication that we know is effective. Again, Vyzulta versus latanoprost. We have clinical trial data on this. We have real-world data on this that basically shows clearly that Vyzulta is superior to latanoprost. We have that from the Voyager study. So in this patient, actually, just with follow-up, the patient did achieve beyond 30% reduction. Pressure went down to 17, which is again the goal in these early stage disease, where you want to keep treatment simple, use a medication that is going to be effective and well tolerated.
Right. I will say one comment on this: the follow-up at 4 weeks. I think I like to give it a little more time before I decide, how well the medication is working over the prostaglandin. So 4 weeks, this is great. They've already had an additional response, but it may take up to 8 weeks or maybe even 12 weeks, to see that additional effect.
I agree, and with Vyzulta and other prostaglandins, you notice that there is an incremental decline in the IOP beyond the 4-week time point. So I often also bring patients back 6 to 8 weeks for their follow-up as well.
Excellent. Okay, so that's the first case. We're going to move on to case study number 2. This is a patient with ocular hypertension with ocular surface disease. So this is a 56-year-old African American female patient who's presented to you as a new patient for comprehensive examination. She's found to have ocular hypertension and also ocular surface disease. She's been prior treatment with artificial tears, but no glaucoma ocular hypertensive medications. Family history is important in this patient. She has 2 older sisters that are being treated for glaucoma. And Albert, I was wondering if you could make a comment on, why is family history important, and how should we be getting that information from the patient?
Yeah, family history is often glanced over, but it's important, as you said. We know from evidence in published papers, clinical trials, on the importance of family history for glaucoma. After all, this is a genetic disease. The closer the family members are with significant disease, the more likelihood are the odds of progressive glaucoma. And I always, when I discuss these things with residents, it's always good to dig in a little bit more with the family history because it's patient reported. At what age did the patients were diagnosed with glaucoma? Were they treated with medications or surgery just to confirm that this was a glaucomatous loss, not some other diagnosis. And how did they do? Like, did they lose their vision? At what age they lost their vision? All these things can factor into the treatment.
Right. So yeah, as you say, it's not just the presence of family history. It's how aggressive is the disease in the family of the patient, and epidemiologic studies have shown that up to a 9 times increase in the risk of glaucoma with a first degree relative that has glaucoma. So here we have the IOP prior to treatment is 19 and 18 by history. Here's her medical history. She does have diabetes, hypertension, and heart disease. She is using metformin, the hydrochlorothiazide, and again, you have the toprolol, which is your systemic beta blocker. No allergies. Good vision at 20/25 in both eyes. External exam is normal. Pupil normal. There is a little bit of punctate staining in the cornea on slit lamp exam in both eyes. And her panometry at this visit is 25 and 26, so in the mid-20s. Corneal thickness, although within normal range, is a little bit on the thinner side at 510 microns in the right and 520 in the left. Angles are open, 3 plus with normal pigmentation. Here's her optic nerve, and I wonder if you could comment on what you see in the optic nerve.
Yeah, so optic nerves look, decently preserved rim. The isn't rule is intact here, but there is a slight asymmetry in the cup to disc ratio between the eyes, with the left eye being, slightly more cupped with a slightly thinner rim. I don't see hemorrhages. You can't really appreciate nerve fiber layer striations or defects here. Although on the left eye inferiorly, there could be some, discrepancy in the striation of the RNFL, but that's what an OCT typically would look into.
Well, let's move on. Here's visual fields, which, we don't have to dwell on this, but these are both normal, in my opinion. All right, so here's the risk factors for this patient. Positive family history, 2 siblings, African American ethnicity, ocular hypertension, pressure in the mid-20s, relatively thin corneas. So we're having a discussion with this patient. The discussion is basically treatment versus observation. If we're doing treatment, what is the most appropriate treatment, and what are the other treatment options? So here again, we have, you tell the patient you have high eye pressure, relatively thin corneas, you're young, but you do have a family history of glaucoma, which is fairly significant. And so options, what would you say would be options?
Yeah, individualized care. That's what we do in medicine. And again, I don't want to highlight the same points you just made, but this is a young patient that has significant risk factors. Pressure is in the mid-20s on the visit today. So I think I would have a discussion with the patient on initiating treatment. And again, here, same theme, you want to keep things simple for the patient for improved adherence. You want to minimize the side effects, so better tolerability. And you want to use the most effective medication that would bring the pressure to target. And for initiation of treatment, if you're looking for 20 to 30% treatment, I think Vyzulta would be a perfect choice here.
Yeah, I think other treatment options you might consider. We talked before about laser trabeculoplasty as an option. In this patient, also because of the ocular surface disease, you could consider one of the newer preservative-free prostaglandin drugs. However, as you say, you may not get as much of a pressure lowering with just the prostaglandin. So it depends on, it's that balance between trying to really get those lower target IOPs. That might be best with something that's not a combination medication, but it essentially acts like a combination therapy where you have different mechanisms of action. So we followed up this patient in 4 weeks, and she was well tolerated on the medication of Vyzulta. She did have a reduction in her punctate keratopathy in the cornea, which was due to more aggressive treatment of her ocular surface disease. Pressure was at target, 18 in both eyes, so that's really about a 30% reduction from the baseline. And so the plan is to continue on the medications and follow up in a few months. So before we get into the wind down, just want to make a comment on both of these patients were young; they were in their 50s, which we're starting to see patients diagnosed at younger and younger ages, and they're living longer and longer. So it's important to number one, get their pressures as low as we can with a simplified treatment regimen, one that is safe, one that is tolerable, and of course one that is effective. You have to think of these patients as having 30 to 40 years of disease that you're going to be following. Well, not me. I'm probably going to be retired by then. So that's an important consideration. I think we should make a little comment on nitric oxide and why that might play into our thought process here. So
Yeah, 100%. I mean, Vyzulta is the only medication that is currently approved that is a nitric oxide donating molecule. So because of that, it's well positioned. It has a dual mechanism of action where you're targeting the uveoscleral outflow with the latanoprost, but you also have the nitric oxide, which we know is important in glaucoma patients. And again, treating patients early, addressing the site of the pathology, which is the trabecular meshwork, is also important in these patients. And being evidence-based, I think we have, when we talk about MIGS, for example, which is what we've seen a lot of talks at AGS on MIGS. You know, some devices have excellent clinical trial data, others have less data. With medications, with Vyzulta, for example, we have plenty data from the clinical trials and from real-world studies that show that it works really well early in the disease process. It reduces pressure. When the pressure is elevated in the mid-20s, but we also know from other studies that it works pretty equally well when the baseline IOP is on the lower side, which is beneficial for a lot of our patients as well.
So before we wrap up, I want to, you did mention MIGS, and we mentioned laser trabeculoplasty as well. Some people may think, well, if you're already doing a procedure like a laser or a MIGS procedure that is targeting trabecular outflow, is a drug that targets trabecular outflow still efficacious? Is it still, something that you'd want to use in that patient after surgery or after laser if they haven't met their target goal? What are your thoughts?
Very nice question. And when you look at the evidence with mixed devices, the vast majority of those patients still require medical treatment. And most of our short of some interventions, most of the interventions are target the nasal angle when we're doing MIGS combined with phaco. So this is an opportunity to target the remaining trabecular meshwork as well. So I think it still has value, but even after MIGS or post SLT.
Right, and I will say also, even if you have a 360 treatment, with a GAT or something like that, I think there's still probably some efficacy in the distal outflow pathway with drugs that cause relaxation of smooth muscle and TM fibers. There have been studies that have shown in the distal outflow pathway there is smooth muscle, and there's probably more active contraction and relaxation in that distal outflow pathway than we formerly thought.
100%. Exciting times in glaucoma, and a lot of innovation, and we have so many tools that we can offer patients to help them preserve their vision.
Yeah. So we'll wrap up. I wanted to thank my colleague here, Albert, and we're going to just end on safety information to reiterate. Vyzulta, which is a latanoprost Bunode, is indicated for reduction of IOP in patients with open-angle glaucoma or ocular hypertension. There may be increase in pigmentation of the iris and periorbital tissues, eyelash growth, and using caution in patients with an active history of inflammation, either intraocular inflammation or macular edema. Be careful in the use of contact lenses, of course, as we would with any medications. And then in the study's most common adverse reactions are conjunctival hyperemia, which is about 6%, eye irritation 4%, eye pain 3%. So very well tolerated medication in the clinical trials. All right. Well, thank you very much.
Well, thank you, Brian.
And we want to enjoy the rest of your meeting.